So, so just as we say that, someone else comes in. Okay, welcome to our Medical Needs in Schools workshop on hypermobility this afternoon. Our presenter today is Nikki Race. She is our senior paediatric physiotherapist here at Ipswich Hospital. Nikki's worked for many years as a paediatric physio, treating children of all ages from 0 to 16. She runs a regular rheumatology clinic where she takes referrals for children with hypermobility. Nikki's very happy to take questions today, and there will be an opportunity for these at the end of the presentation, but if you want to, you can always add them into the chat bar as we go along, and we can feed those to Nikki if you've got no sound or whatever. So Nikki, welcome and thank you for giving us your time today to tell us more about this condition.
Hi. Thanks, Kate. So I hope you can all hear me. Can you hear me?
Loud and clear.
Brilliant. Okay, lovely. So yeah, so as Kate said, I'm one of the physios that works in our team, and hypermobility is something that we treat a lot. It's something that comes across in many different parts of our job, but as she said, a lot of them come through our rheumatology clinic. I'll just go on to my next slide. So today we're just going to talk a little bit about what is hypermobility, what signs and symptoms there are, how we manage that and the role of the physiotherapist, and how ultimately for you guys how you can support the child and the family with the hypermobility. I've got a couple of little case studies of sort of classic kind of referrals and patients that we get, and then we can have some questions and answers at the end. Lovely. So what is hypermobility? So it's sort of a nice definition of that is that it's a description of joint movement, and is what it says. It's hyper, so it's bigger.
Sorry, I'm turned off.
Bigger movement. The ligaments that offer stability to the joint, that is their main role. They stabilize joints, are lax, and therefore the joints have more movement and become more flexible. Hypermobility lies within a spectrum. Mostly common condition within general population, and many individuals do not experience any significant difficulties. So a lot of you sitting there today probably have some element of hypermobility, and it doesn't affect you in any way. Hypermobility should be regarded as a normal variant. So this is the term that we use across paediatrics and health. People come to us for referrals for all sorts of things: in-toeing, out-toeing, bonies, hypermobility, and all of these things are considered to be normal. But the difficulty occurs with hypermobility when there is imbalance of muscles or there is deconditioning, because the muscles are there to help to support the joint along with the ligaments and the flexibility and the stability. If the muscles are weaker, the ligaments are flexible, then the stability is a lot worse. So for you guys, hypermobility affects between 8 to 39% of school-age children. Girls more commonly affected than boys. And obviously this can have an impact on their days in school, their PE, and ultimately their education. It can occur throughout the body, anywhere, and we mainly assess hypermobility. One of the key tools we use is the Baton scale. Now this looks at various joints as to see which ones are bendy, and then we get a score out of 9. For children under 10, 6 to 9 is considered hypermobile, and anything as beyond that point as an adult is considered 4 to 9 is considered hypermobile with an adult. So having a little look at your hands now, you might find that you have some bendiness. I'm really bendy, so my fingers bend back, but if you want to have a look at your little finger, some of you might be able to bend your little finger right back. That is considered hypermobile. That's one of the things that we look at. We look at taking our thumb to our wrist, and some people can do this. Another one is the elbows. Do the elbows go beyond straight? As you can see, mine do a little bit. And again, that is considered normal, but I'm already scoring a 4 out of 9 there. So I would be considered hypermobile, but I have no issues with that at all. Okay, next slide. So one of the hypermobility is considered to be sort of something that affects the connective tissue. such as the ligaments. And another condition that you might have heard of, I know Kate mentioned a couple of different conditions to me when we were talking about doing this, and one of those is Ehlers-Danlos syndrome, and that might be something that you've come across in school before. So again, there is a series of syndromes. They're hereditable connective tissue disorders, and it affects the collagen in every part of the body. So you can have loose, unstable joints that can easily dislocate. Some of the symptoms include joint pain and clicking, tiredness, fatigue, skin that bruises easily, and they can even have problems with digestion and problems with their heart as well. So but again, it's on a spectrum, so it's a difficult one. It's not always diagnosed. It used to be diagnosed a lot more readily in the past, but in 2017 they designed a new classification for it, and now it's much more stricter criteria for you to be able to achieve those Ehlers-Danlos the diagnosis, although you can be diagnosed with hypermobile Ehlers-Danlos, which again is just another type of this spectrum. There are 13 different subtypes of Ehlers-Danlos. I don't know what they all are, but they can all be tested but genetically, but there is no test for the hypermobile Ehlers-Danlos. Hence this strict criteria, which I'm not going to go through today because it's quite intense, to diagnose that specifically. Okay, that's one of our first ones, and I'll get on to how things differ a little bit later on. Another one that you might have heard of is Marfans Syndrome, and the picture we have here is Michael Phelps. As we know, he was a fantastic Olympic swimmer, and he actually has Marfans. So although you've got this connective tissue disorder that can have some other issues around it, actually doesn't always stop you from doing your best physically and with sports, etc. This is an hereditary connective tissue disorder. The gene defect causes abnormal production of fibrillin, resulting in parts of the body being able to stretch abnormally when placed under any kind of stress. So classic symptoms with these people are they can be really tall. Their arm span is generally longer than their height, and that's another classic sign. They're hypermobile, so these guys will score 9 out of 9 on that Basin scale we talked about earlier. They can have some facial features, deep set eyes, overcrowded teeth. They often have a high palate in their mouth. And they can have a pigeon chest or a dipped in chest and scoliosis. So when we see any of these children come into clinic, or children that we think might be Marfans, we will do another set of a scale to test where we think they might be. Because of the nature of this condition and the stretchiness of all the tissues, the abnormal stretch, there can be some issues with eyes and heart. So we always have to get these checked out because they can have like optic lens ruptures and aortic rupture as well. So quite serious and needs investigating. But again, very, very rare. So what are our common symptoms of hypermobility? So I know I've talked to you about 2 different types, but they're sort of more the ones that have got an actual syndrome. They've got the name. Hypermobility presents very much like this little boy who's sitting here on the chair. So their common complaints are they click a lot, they have a lot of pain in various joints, they can suffer with fatigue, they get tired very, very quickly. They can have difficulty sitting still and have this kind of low tone posture where he's quite slumped down. Often they have flat feet because they're very flexible in their arches, reduced balance and coordination, and weaker in their core. Sometimes there can be a reluctance to walk any distance or participate in physical activity because it's so difficult for them. They fatigue very quickly, so that's hard. And then often they struggle with the fine motor skills such as handwriting, tying shoelaces, catching, throwing balls, those kind of activities. So this little boy here, I can see straight away from his picture, he's got really low tone. So his muscle tone is just quite floppy. And we see that a lot in teenagers. This is a very classic sort of teenage picture, isn't it? But with hypermobility, it's a little bit more pronounced. He's got that sort of chin poke. His chin comes forward because, again, he's slumped in the middle. He's got his toes, his heels off the ground, and that's just to try and engage a little bit of muscle tone, to try and pep it up a little bit. And it's much easier for him to put his heels on the ground than it is to sit up tall and support himself like that. He's got his knees apart, making his base of support, so the base at the bottom a lot bigger. Again, that's much easier than standing with having his knees together. And ultimately he's got his hands resting on his knees, which means again he doesn't have to rely on those core muscles. He can just sort of hang there, really. You'll see them in standing in similar positions. I'll see if I can demonstrate, where they'll just be kind of hanging on the hamstrings and just floppy. And then again, it's that spinal posture is just all out of alignment. Okay. So how do we manage hypermobility? It's the first thing that we do is we try and normalise it and try and empower children and young people and their families to understand the management, develop the confidence and the skills and knowledge to manage the self-management strategies. So a lot of these children have been to the GPs, or their families, someone in their families had hypermobility, or a parent or grandparent. And in the past, it was the advice was, don't do those sports. Don't do those things if they're going to hurt you or aggravate you. And actually, we know now that that's completely the wrong advice. We recommend the opposite. It's be active, do as much activity as you can within your limitations and pacing. Keep busy, you want those muscles to be strong to support the instability that you've got around those ligaments and around the joints. So lots and lots of reassurance is needed because of the sort of the previous history and the knowledge that they've been given before. They're a little reluctant to accept that perhaps on the first appointment. We encourage them to pace their normal activities. So, if I went out and ran a marathon today, I just wouldn't be able to do that. So there's no way. These children, they might not have done a full lesson of PE. So in which case, that for them is a bit of a marathon. So that, it might be that they just do 15 minutes, have a rest. Can they do a little bit more, or do they need to build up on that a little bit more gently? And we do exactly the same with our specific physio exercises. We try and keep our exercises to something that they like doing, something they enjoy. So again, I always say to these kids, or any of the kids that come to see me, it doesn't matter what you do as long as it's active. It could be swimming, it could be cycling, it could be karate, dance, whatever, it doesn't matter. And if they enjoy it, then they're more likely to continue. So we do use targeted exercise programs. So as I said earlier, core strength is something that we really try and focus on because they tend to be quite weak in the middle. I love to use the analogy that if our bodies are made of jelly, and when you're standing and sitting like this all the time, you are a bit sort of wobbly and jelly-like. If your body's made of jelly and you stick arms and legs in it, they're just going to flail around, and that's going to be really hard to control. If your body's made of concrete and you stick your arms and legs in it, they're going to be much more solid. So we know that if we strengthen up the core muscles, the other muscles can work a lot more easily and more active in a better way. That's even just about sitting on a chair. So if your core strength's here, yeah, you can sit and write a little bit easier. It's not so hard as if you're down here writing. And we all do it. We've all seen laying across the desk. But if we can sit up 90 degrees, nice and tall, it's a much better position to be in. So that goes along with the postural advice as well. Another really good thing that we do here, it's been a bit limited over COVID, is Pilates. So Pilates is perfect for hypermobile kids because it really focuses on that core. It's not overly high impact, so they don't end up getting the pain around the ankles and stuff with the impact, because that can sometimes cause discomfort if they're having to stabilize too much, or maybe they twist their ankle. So yeah, that's a really good thing to do. Swimming, again, for the same reason. Cycling, again. And the other things we do is we liaise with the multidisciplinary team here at the hospital. So we might need to get a rheumatologist involved. Is there some swelling that we need to investigate? Do they need to see a paediatrician? Are they demonstrating some of those symptoms of the Ehlers-Danlos or the Marfans? Do they need a paediatrician to have a look at them as well? So we might liaise with them. liaising with the guardians and the parents, really trying to bring that home, and then with you guys as well. So quite happy to write letters or speak to teachers about what that child can be doing to help themselves. Okay, so PE and support. We get asked quite a lot of these questions, and parents are often a bit confused about this. Some schools in PE will push children to do sport, and it is part of the curriculum, and I always say that to kids. You should always put your kit on, even if you're only going to manage 5 minutes. Go to the PE class, be willing to participate. But what we must remember is though these children have the stamina to manage that full PE lesson, can they manage even half of it? You know, is that PE class that a marathon to them? So we need to really bear that in mind. Does it need to be built up slowly? Bear in mind that contact sports will probably need more preparation and more strength. So if you've got somebody who's really weak and perhaps they might be dislocating some of their joints, they might have some issues like that, because some children with hypermobility do, they're not going to struggle. They're going to struggle, sorry, with the contact sports. So the other thing is, if you've been bendy all your life, you might actually hate PE because you find it really, really hard. And as you get to be a teenager, you know, the pressure that you get from your peers, and you know, being picked to play sport, and they might just dread it. They might be the worst day of the week. So and they find it difficult to keep up with their peers. They might struggle with coordination because of the core, and they don't really know where their joints are in space because they've got this extra flexibility and weakness. So this makes like team sports and contact sports quite challenging for some of these kids. That in turn leads to a lack of confidence perhaps in performing PE, and even dread. Oh my gosh, I don't want to drop the ball, so I don't want to play. It's much easier just to avoid. So bear that in mind if you've got some kids that are struggling with those kind of issues. I think in schools it's really important to have an opportunity to put on a variety of different sports, different activities. You know, if you've got a child that's got a problem, have they got some exercises they've got from the physio? Could they do them then? Is there a gym they could use? Could they go off in a smaller group and do something else? I know, you know, you're teaching big classes here and it's not always possible, but you know, encourage them to have a rest. Can you come back and have another go? You know, even if it's just for short times. And encourage them, you know, congratulate them. Well done, you've done really well today. You can go and rest now, or you can go and do your stretches. So I've already touched on Pilates. It's a fantastic thing to do. In that we use gym balls as well. So I don't know if you've done Pilates before. A lot of it is based around the floor. It's based around posture and core. Gym balls are really, really good. I should have brought one in, but actually even just sitting on a gym ball can make you work your core muscles. So you might find that actually if a child's a bit fidgety in class and they're really struggling with that, actually bring the gym ball in. Can they sit on the gym ball? Does that help? Because it makes them engage their core. They can bounce a little bit, and again that will help with that kind of coordination and that kind of distraction that they might have, or that fidgetness that they have. The occupational therapists also who we work with, they sometimes give out these wobbly cushions. I don't know if anyone's got any experience of using those, and they can be really good, especially with the younger ones. They're just like a little half ball sort of cushiony thing, flat, that you sit on, and it's just constantly moving, so it sort of helps with that fidget. Working on coordination is really good. So just doing throwing and catching, kicking, all those kind of things. Golf, whatever it is, doesn't matter what it is. Balloon tennis is a great one. So, you know, the balloon's not going so fast as a ball, and it doesn't hurt if it hits you in the face. Batting a balloon to each other can be a really nice one to do. And a lot of the primary schools do gym trail, or used to, and that was been brilliant for helping these kids. Anyone who you think's got hypermobility, stick them into gym trail. It's great because it sort of targets all of those things. And ultimately, try and do activities that the child enjoys, because if you're going to engage them in any way, it's going to be fun. And you know, if they're enjoying what they're doing and don't see it as a chore and don't dread it, then obviously they're going to engage more, they're going to get stronger, their symptoms should lessen. Okay, so this is a sort of a classic patient that we might see in our department. So I've done a younger one and an older one. So 5-year-old boy referred with history of falls, difficulty with his fine motor skills, which has been reported by school. So we get this a lot. So schools have asked parents to go to the doctors, and then they end up with us. Mum reports that he often wakes up at night and he's got pain in his legs, and this is a lot worse on a busy day. There is a family history of hypermobility, but Mum's main concern is that his feet roll in, and he's got flat feet, and sometimes he walks on his toes. So those of you who've worked in primary school have probably seen this child lots of times. So what we do on examination, he's found to have quite flexible feet and global hypermobility. So just to say, hypermobility is, as I said before, a normal variant. It's more common in very younger children. So he's 5. We would expect him to be a bit bendy. We would expect him to have flat feet. In actual fact, the arch of the foot isn't fully developed until about age 7. And some people never develop an arch, and that's completely fine as well. On assessment, as I say, there was no structural issues and there was no red flags. So pain at night, we would worry about that. We'd be really concerned because that can be a red flag that there's something nasty going on. So we would rule that out. But often it's just because of the busy day aspect, and these muscles are tired. So treatment we would give this person and his family, we would reassure them. So it normalised that hypermobility is normal. And so is the flat feet. We give advice about wearing good footwear. So sometimes if you've got a bit of a flexible foot, wearing a trainer can be really helpful. It's a bit firmer at the back of the shoe. Sometimes they have a little bit of an arch. Trainers tend to come a little bit higher on the foot than a classic school shoe. And you can't sort of fold it in half or wriggle it around. It's quite a solid sort of thing. If they're really bendy, sometimes a high top will work just as well. And school, obviously there's an issue around that with schools because a lot of schools want school shoes, so we'll happily write letters, but supporting that child, even if it's just for 6 weeks, 8 weeks, if it can make a difference to their school day and their evenings, then it's worth doing. So we would advise to increase their physical activity generally, because actually getting a 5-year-old to do any formal exercises is quite hard. So swimming, play parks, play centres, all of those things that are going to help with his development and build over his general strength. We might issue with some balance exercises if he's up for it, and some core work. Our younger ones, we tend to do things like bear walks and, hands and knees, crawling, that sort of thing. Standing on one leg, the balloon tennis, standing on one leg, that kind of thing. And we'd also sort of liaise with the school, write some letters if need be. And if we were concerned more about the fine motor skills or schoolwork with handwriting and such, then we can get an occupational therapist involved, or school can actually refer directly to occupational therapy. They can come in, do an assessment. I don't know if any of you have had any experience of that, but they'll give like a slanted table, little tray thing. They can talk about the wobbly cushion that we talked about, and different types of pens and things like that, and can help with advice around that. Someone like this, I probably wouldn't need to see again unless I was worried a little bit about the night pain, but I would leave it open appointment, probably for sort of 3 months, and that often helps to, reassure the parent as well. So that is our sort of classic boy. Oh, the toe walking, just to mention about toe walking, quite common in a hypermobile child, and they just do it to increase their tone. So if we go back to that little boy, where is he? On his toes. So he's doing that to increase a bit of muscle tone, to make your life easier for him. The kids that walk on their toes sometimes do that for exactly the same reason. So yeah, that's sometimes an issue. Okay, case study number 2 is our 13-year-old girl. Referred with recurrent history of clicking hips and subluxing knees. So subluxing is not quite full dislocation of the knee, so it comes out a bit and then goes back in. Not very pleasant, but not as bad as a full dislocation. Sometimes they get a bit of swelling, poor posture, and this girl particularly didn't like PE, but she used to swim loads. Okay, so again, family history of hypermobility. Mum had lots of issues with her feet and her back and doesn't want her daughter to suffer the same thing. This is a really common complaint. They worry so much, but as we talk to parents, the management is so different now. Whereas before it was don't do anything, now we're like, do what you can. So on examination, she's really tall and slim. She's got a very thin foot. She has a very low tone posture, floppy, and the Baton score, when we're looking at the joints, what we did at the start, is 9 out of 9. So she is bendy, she's hypermobile. There is no swelling and there's no structural concerns. So again, reassurance, plus, loads of that. Explain management of hypermobility. Encourage the increased activity. You know, what we find sometimes is that, you know, especially in teenagers, they do a lot of activity as a primary school in primary school. They go to high school and they stop all their clubs. You know, they can swim by then, so they don't go anymore. Actually, stopping those things is the worst thing they can do. They need to try and carry on and try and keep active. So yeah, encourage normal activity, suggest going back to swimming, try some Pilates, what about maybe some cycling, liaise with you guys in the school to give you any advice that you might need, or just advice about PE. Again, footwear advice. Sometimes if they're not getting better with the physio, we sometimes use an insole. If someone's got a really flexible foot, that can have an impact further up their body in their knees and their hips, even in their back. And sometimes what we find is just by popping an insole in just to give a little bit of offload into the foot can make a massive difference further up. It's not something that we do straight away because we like them to be able to try and improve the strength if they can. So with this, someone like this, because it's been going on for a long time and she's generally quite weak, well, I'll probably follow her up one more time, and because of the subluxing knees. And then we progress this person as able, we might refer them into our Pilates class. We aim to see the hypermobiles no more than 3 times, because actually it's self-management. That's what they need to do. It's just about getting strong. Yeah, and I think that's it. And there's just a couple of references at the end here, just to say this one here, the APCP, which is the it's the physio, chartered physios for paediatrics. This website is really good because actually there's a fantastic leaflet on there called Symptomatic Hypermobility. Now that leaflet gives really good general advice to parents and families, but it might be useful for you guys to have a little read of it, because it's just got some, we've covered everything pretty much today, but it's quite a nice one to have a look at. So has anyone got anything they'd like to ask, or any people they would like to problem solve? Or
is it okay if I ask a question, Kate? It's Alicia from Parkside.
Of course, yes. Ask away.
Sorry, I came late. Apologies, I did put it in the chart because I had a home visit. But you mentioned about certain equipment that will be useful and of benefit to children. Now, is that something we at school can get, or is that something parents can get via the physio? How I'm just thinking of one particular girl that we have in Year 8. So
normally, well, it's really difficult because they have a bit of a cut-off. We'd rate it's occupational therapy, so they tend to be more involved in equipment and that side of things, and they're involved in sort of the handwriting type aspects of things. Unfortunately, they cut off at Year 7, which is a real shame. Yeah, but we can give some general advice. So things like oh, I've gone a bit fuzzy. Is everyone hearing me all right?
Yeah, I can hear you.
Oh, okay. I thought I'd gone a bit fuzzy. Different types of pens can be quite useful. Something a bit thicker, often if they're really bendy in their fingers. So sometimes their fingers sort of bend at the end and they really struggle to hold a pen, and they're right down at the tip, and it's just exhausting to write like that. So trying different types of pen is good. Is that all right? It's still quite fuzzy. Oh, okay, it's gone. And we talked about the wobbly cushions. So you probably can buy them. It would be useful to get some advice, probably more from a health professional about that, just because it might not be the right thing for them. And I think, are you high school, Alicia?
We're Key Stage 3, so we're Year 7, 8 and 9. And this particular girl sits also under the hospital of Dr. Burgess.
Oh, yeah.
So is this something that I could link with her about?
Yeah, you could certainly ask her. She might be able to make a referral to OT. Is she under physio?
Yes, she is.
Oh, okay. That might be something worth mentioning. The issue you've got with all these equipment things and wobbly cushions, pens, slanted tables, is once they get to high school, they don't want to use them, because it's something else that they have to, they still stick out a bit, and teenagers don't want to stick out, do they? And
No, no.
often they're not in the same class the whole time, so they have to carry all that equipment around with the school with them. So it's not always the answer, but yeah, it's definitely worth considering.
Okay, thank you. Thanks.
Okay, no problem. Any other questions from anyone? Anyone got a person or a case that they think might be useful to talk about?
Yeah, I have a question, please. It's Leslie. I'm from a primary school. I have a lot of parents telling me that their children are in significant pain because they're hypermobile.
Yeah.
And requesting, doses of Calpol. Not terribly happy when people say, can you give them Calpol every single day because they're hypermobile?
No, it's a difficult one, isn't it? Yeah, I think from experience, Leslie, you're not the first teacher that I've spoken to about this, to be honest. It is quite common. Yes, Calpol can be really useful at times for short periods. What I would suggest is actually, if it's longer term use, because obviously there's sometimes if it's going on for a long time, there's a sort of a safeguarding sort of element there, isn't there? Is ask them to provide information from your GP. And ask the GP to say, because prolonged use of paracetamol is not really beneficial, is it? It's not, if you, like you say, at a young age.
I just thought, I understand there must be a degree of pain with hypermobility. I do understand that, but I presume it just doesn't get any better.
No, that's not. I think the issue is they do get pain, as we touched on. And if you think about all the things we talked about, the flexibility and the posture and how difficult and the fatigue and all those things, and actually even all those things going on, even the concentration can be affected, and then pain, is the biggest one, and that's exhausting as well. Is it can get better, but they have to get stronger. And if you think about a child being a bit of a moving target, so they're growing constantly, they grow to a certain degree, their muscles might just about catch up, and then they grow again and their muscles aren't strong enough again, so they have to work even harder. So that's why it's so important, and we try to engage with these kids to do regular activity so that they are keeping up with themselves.
Okay.
I mean, if you're really worried about this, you could suggest that they go to see their GP and ask for a referral to physio.
Yeah, I just think sometimes it's a kind of parent perception. My child's in pain. Here's a bottle of Calpol. Please give it to them every day.
I would question that if it's daily. Yeah, I think if you've got a child who's broken their leg and they're asking you to do that, you don't mind so much, do you? Because it's you can see there's a thing. But if it's indefinitely, then 100%, I think you're completely within your rights to ask for a letter from your GP. Yeah.
Because I just thought, well, maybe on a day that they've had PE, then maybe, but not before.
I agree.
Not before PE.
Do you have a policy for giving pain relief at your school?
Yeah, and it has to be prescribed, but the parents come in and say, well, this is a diagnosed condition. This is, it just leaves us in a bit of a sticky place. So we're trying to kind of just weave our way through it, without.
If I would say if a child's needing pain relief every day because of hypermobility, that is not uncommon for a child to need pain relief, especially like you say on a PE day. And if they've not been seen by anyone, in the hospital, a GP, fine. But if they're really struggling that much, then that GP ought to be referring to paediatrics, really. Because that amount of pain relief over a long period of time is probably not doing anything.
No.
Yeah.
Lovely. Thank you.
Okay, no problem. Anyone else? No? Cool.
There's nothing in the chat bar, Nikki,
Okay.
and I'm very conscious that you have a patient that is coming at 5 o'clock, so
Yeah.
you might have time to have a cup of tea before.
Oh, that'd be nice. I feel rather dry after that.
Nikki, we are going to put your slides up on our website, and if anyone wants to get in touch with you, are you happy for them to contact you directly?
Yeah, I should have put my number on there. So yes, if you ring through to Ipswich Hospital and ask just the main switchboard and ask for children's physio, then yeah, absolutely.
Okay, or you come through the medical needs in schools, and I can always pass a message or answer any queries in the usual way. So
yeah.
okay,
Yeah, that's fine.
Thank you, Nikki.
Lovely,
very
no
much.
problem. I hope that was useful, and yeah, please give me a shout if you need more info.
Lovely. And I'm just to remind everybody else that our next medical needs in schools workshop is going to be on cystic fibrosis. We have Dr. Imogen Rose, who's going to be the presenter on the 21st of June, and that's going to be 4 o'clock. So look forward to meeting up with some of you there. Okay, once again, thanks very much, Nikki. I know you're very busy, and I'll catch you, well, hopefully stay on for a minute and we'll have a little catch up. Take care, everyone. Bye-bye.